Hello, everyone. Welcome. My name is Denise Rogas of ThyroidChange, a thyroid health and wellness website and patient advocacy platform. Today, I'm interviewing Dr. Tiffany Mullen, an integrative physician and the co-founder of Vytal Health, and we'll be discussing an integrative approach to thyroid disease diagnosis and treatment. We'll be discussing the difference between integrative medicine and traditional medicine. We'll dive into how she typically treats thyroid conditions, other things she screens for, and reasons why general practitioners are having a difficult time diagnosing and treating thyroid conditions. And at the end of this 20 to 25-minute interview, we'll have some time for your questions. So we welcome you to get your questions in the comments below. So let's get started. I'll start with the bio for Dr. Mullen. Today I'm interviewing Dr. Tiffany Mullen, DO, and certified with American Board of Integrative Medicine. She is an integrative medicine specialist and has over 23 years of experience. She is also the co-founder of Vytal Health, a telemedicine company based in Milwaukee, Wisconsin, servicing patients from all over the country. Dr. Mullen's first role in healthcare was that of a patient diagnosed with juvenile rheumatoid arthritis at a young age. She experienced the difficulties of living with an unpredictable and painful illness firsthand. After navigating a confusing and frightening healthcare system without finding genuine, compassionate care, she decided to dedicate her practice to providing integrative care for her patients. Dr. Mullen is duly board certified in Family and Integrative Medicine. So welcome, Dr. Mullen. Thank you for coming.
Talk about. Hi, Denise.
And hello, thank you. Thank you for coming here today.
So glad to be here.
Yes. So you're based in Milwaukee, Wisconsin. Is this where you've been practicing medicine prior to starting Vytal Health? And what did that entail?
Yeah, I am in Milwaukee, Wisconsin, the heartland, we like to call it. I've been practicing here in Milwaukee for, gosh, I think I'm in my 16th year here, which, I mean, you said 23 years of practice, and I said, who is this woman? So 16 years practicing in Milwaukee, and prior to that, I was in Phoenix, Arizona. That's where I did my residency. And I stayed there for a few years post-residency to practice privately and then in academics before moving back to Wisconsin. I'm from the Midwest, so decided to navigate back to the Midwest and started practicing here 16 years ago, I guess. So I feel like it's not been that long, but it certainly has.
Great Midwesterner here too, from Detroit.
So. Oh, that's right. Yeah, that's right. Yeah, Midwest is a great place to be. It's such a wonderful place to be, and having all this wonderful fresh water, the Great Lakes, et cetera. It's just lovely. So we're lucky.
Well, thank you for coming here today. So a few years ago, you, along with Alex Yampolsky, is that the pronunciation?
Good job.
He's a compounding pharmacist near you. You and him decided to get together and create something called Vytal Health, a telemedicine company with a functional medicine approach. So what led you to this path?
Yeah, so Alex and I go way back. So prior to practicing at Vytal Health and founding Vytal Health, I was working at a large healthcare company called Aurora Healthcare, really just the hugest nonprofit employer and largest healthcare traditional and sort of corporate healthcare company in Milwaukee and throughout the state of Wisconsin. And Alex and I both worked there. I was the director of integrative medicine, which was a department that essentially founded. There was some complementary medicine activities happening before I moved to Milwaukee and joined Aurora. And during that time I was practicing, I thought, boy, I'm a person who utilizes integrative care in my own autoimmune condition. And I just see so very little of it here in the traditional practice. So I said, gosh, we need to have more doctors doing this. So I actually recruited and helped get training for at the University of Arizona, which is where I did my fellowship, for 22 doctors. And it ended up being the largest department in the United States, which was amazing. We also had acupuncture, chiropractors, health coaches, all different types of practices, massage therapy. And we ended up being this huge department across the entire footprint of the organization. Alex is a pharmacist by training. He left the organization a few years ago, 5 years ago now or so, to get an MBA. And so when he came back to Milwaukee, the two of us were looking at each other, knowing that traditional healthcare was underserving so many people, not just in thyroid, but across the board. This transactional nature of the 10-minute visit, prescription is the only tool in the toolbox, made absolutely no sense to me for years and years and years. And I was trying to figure out a way to do it. And then when Alex and I came together, and I realized that he had some of the skills and some of the knowledge to sort of round out the offering, we both leapt out of traditional healthcare and founded Vytal Health. And we did that in 2018 as a telemedicine company before COVID, before telemedicine was really, I think, in the forefront of people's minds and something that they were very used to using. We were kind of on the cutting edge, offering consultations in functional and integrative medicine for patients across the country from physicians across the country on our platform. So we've been at this now for almost 3 years.
Yeah, and now COVID hit, where telemedicine, everything online is the norm.
Yes, made it so much easier, because when I'd walk up to somebody on the street in Milwaukee and I'd say, hey, we do telemedicine, they would just look at me like, what do you mean? And I say, oh, we're going to, we have our visit online and we can see each other by video. And they looked a little, skeptical. But then in COVID, so many people saw doctors. It was their only option, essentially, to see doctors via telemedicine. And now it's like, oh, yeah, sure, I know how to do that.
Yeah.
So it really lowered the barrier to entry for us.
Yeah. Excellent. So can you define then, I think a lot of people in our audience and a lot of people in general are a little confused about what the difference is between integrative medicine and functional medicine, if there's a difference between them or is it used interchangeably, and the difference between that and traditional medicine. I think a lot of people in the audience think that it's just a completely holistic or completely natural way of treating disease. But I think I believe there's a lot more than that. And I hope
I agree.
I hope you can explain the difference for us.
Absolutely. I get asked this all the time, because all of these terms are kind of like, people don't exactly know what's the difference between integrative, functional, naturopathic, holistic. What does it all mean? So that's a wonderful question, and I think it's worth explaining. So I always think of these types of practices as falling under a holistic umbrella. So under that holistic umbrella, you have integrative medicine, functional medicine, naturopathic medicine, and I would say other allied health practices like massage, acupuncture, chiropractic, et cetera. So all of us who are offering practices that I define as things that you don't learn in medical school, things that aren't taught in the traditional medical school training, are under that umbrella. So those of us who are physicians and who have come up under the traditional training, and I'm a DO, but this is true of DOs and MDs, where we come up under the sort of traditional training, medical training model. And then because in that model, we don't have any training in these practices, or even in things that would make sense to know about human health, like nutrition, like sleep, like managing stress. All of these things are not emphasized. It's a disease model, essentially. So it's incredibly important to know, but it's limiting, because if you want to be able to offer people a repertoire of approaches to a medical condition, you're limited. So those of us who practice this way go back and get additional training. I think about integrative medicine as being a collaborative model of care that looks at health as being something that can be lifestyle based. So a heavy emphasis on nutrition, a heavy emphasis on understanding the role of supplements in addition to traditional medical care, and then how to utilize other practices of medicine like Ayurveda or traditional Chinese medicine or herbal medicine or even homeopathic medicine as a complement to how we practice in traditional care. In functional medicine, what we're talking about is unpacking a health condition down to the root cause. So the emphasis is really more on this, what we call systems biology approach. How do all of these symptoms that a person is experiencing come together from a bio, psycho, social, spiritual aspect? And how do we unpack all of that down to the very root and try to solve the problem to the best of our ability? And so again, there's a traditional medical training layer there that we rely on. So we prescribe, many of us do procedures, et cetera. But then there's a curiosity factor layered on top of that, where we're not just saying, I see your symptoms and I'm going to give you prescriptions for those. We're saying, I want to unpack this with you and understand what might be going on and solve at the root. So I hope that there's a lot of crossover, but I hope that helps a little bit.
Absolutely. And that's what I've always mentioned to patients and my audience too, that it feels like it's a complement to a traditional medicine too, or what traditional medicine should be.
Absolutely. I mean, this is not throwing traditional medicine under the bus, although I do like to do that regularly. But it definitely is building on traditional medicine, building on the fact that we have access to great health benefits in traditional care. I myself am a recipient of traditional medicines, traditional therapies, surgeries, et cetera, with my RA. But it's not the be all end all. There's so much more that you can do to restore health in a person than just prescribe.
Yep. Okay, so let's switch gears a little bit and start a little conversation about thyroid conditions for our audience here at ThyroidChange. What, for you, are the telltale signs of a thyroid condition?
There are so many. And I think this is probably where people feel so frustrated, because it's so obvious to those of us who practice this way when somebody comes in and they're going to have thyroid dysfunction. But I think the classic ones are fatigue. And it's a fatigue that I think when I ask my patients, I say, is it mental fatigue, physical fatigue, or both? And they universally say it's both mental and physical fatigue, because it feels different. Inexplicable weight gain or difficulty with weight loss. Having voice changes can be part of it. Having hair, skin, and nail changes, disruption in sleep, palpitations, so many changes in bowel. All of a sudden, people are having constipation when they didn't before. So they're really, because thyroid is such an all-encompassing hormone, as most hormones or all hormones are, there really isn't an organ system that you can think of that wouldn't be touched by a thyroid condition. But those are probably the classic ones. And there's so much crossover between thyroid symptoms and other endocrine or other hormone problems that if you just hone in on thyroid, sometimes you're not going to help the patient too. And we'll probably get to that, but I think that's an important thing that we do in integrative and functional medicine, is think outside the box a little bit.
Right. And, on some medical websites, they'll list like the 10 most common symptoms of a thyroid condition, or hypothyroidism, or hyperthyroidism, but not everybody can have all of those symptoms. They may only have a couple, or not. So for example, with me, I didn't have weight gain. I remember a couple of doctors told me, well, we don't think you have a thyroid condition, even though it ran in my family and I had all the other symptoms, but I didn't have weight gain. So they ruled it out.
So it couldn't possibly be that, right?
Exactly.
Yeah, that's sort of that systematic, non-personalized approach that is infuriating, I think, when you're trying to get a problem solved, when you don't fit into the box and therefore it can't possibly be, and you get dismissed.
Yep.
So yeah, I totally relate to that.
So do you see a lot of variation and degree of intensity in your thyroid patient symptoms from patient to patient?
So much. And the interesting thing is that people can be profoundly impacted by a change in their thyroid, even within the normal range. They can be profoundly impacted if their thyroid antibodies increase a little bit. And so if you're not looking at all of those markers, you're not going to catch it. So for example, my TSH, and I don't have a thyroid condition, my TSH lives in the 0.5 to 1 range. If you measured my TSH and it was 4, you might pronounce me normal, but I can tell you a 4 times TSH, I would probably notice that. So even within the realm of normal range, if somebody is shifting around, they can profoundly feel the impact. Conversely, I have patients who walk around with hypothyroid numbers, but who feel just fine.
Yeah.
And that you try to put them on thyroid medication and they actually don't feel good on thyroid medication. So I think, again, individualizing the approach is incredibly important, because the way the patient feels is as important to the treatment as the numbers.
Exactly. And someone who can have one number can feel like total death, while another person might feel, well, they might be experiencing some symptoms, or they just feel a little off. So
yes, exactly. It's so subtle. I have some patients too who are so exquisitely sensitive to thyroid medication that we're compounding it and we're tweaking it by 1 microgram at a time.
Wow.
So if I climb up 1 or 2, they feel totally different. I mean, so I think again, this is just having somebody who's very knowledgeable about thyroid will get you there.
Mhm.
If you don't have somebody who's willing to do those changes that you specifically need, it's probably like in your case. I mean, this was your story, right? You just couldn't get there until you had the right treatment for you that worked. And
Right.
that's the difference between people.
And so, what thyroid labs do you typically run if you suspect a thyroid condition, whether it's hypo or hyperthyroidism?
Yeah, I always look at TSH, of course. I mean, everyone bashes TSH. Oh, it's not the only thing. Well, yeah, but it's important to know. I personally like free T3 and free T4. I know some practitioners do total T3 and T4, which is perfectly fine. I'm just used to looking at free T3 and free T4 as being a really great way to look at how well someone's thyroid is actually manufacturing and converting thyroid hormone. In some patients, I do reverse T3, not all. And then I always check antibodies because it's shocking to me. And by antibodies, I mean thyroid peroxidase antibody or TPO antibody and thyroglobulin antibody. If I suspect they have Graves' disease, I'm also looking at thyroid stimulating immunoglobulin, which is very specific to Graves'. But it shocks me how many times people come into me with a diagnosis of hypothyroidism and they're sort of trying to figure out how to manage it. And I'll ask them, is it autoimmune? And they'll say, I don't know. And they've had it for 10, 15 years and they don't know if they have autoimmune disease. And that really bothers me a lot, because there's so much that you can do for autoimmune with thyroid. So yes, those are really the typical sort of thyroid-based labs that I do. I love also doing nutrients. I look at ferritin and iron. I look at magnesium,
Mhm.
RBC magnesium, selenium, iodine, urinary iodine specifically, and just really making sure that from a nutrition standpoint, all of the nutrients that are exquisitely important to the way that the thyroid function are all optimized alongside those thyroid numbers. And then we get into things like adrenal function. Sometimes the sex hormones are involved, estrogen, progesterone, testosterone. So, it really just depends on how the person is presenting, but it can be quite comprehensive. And I think that's the difference between just getting a TSH and then having an integrative or functional approach. It's much deeper and much more personalized.
Yeah, absolutely. And so many things impact, as far as, like you said, the
Yes.
nutrients and the other sex hormones.
Mm-hmm.
It's so important to get that comprehensive
Yes,
lab work done.
exactly.
Okay, so once a person is diagnosed in your practice with hypothyroidism or Hashimoto's, how do you typically treat them? And then how would you typically treat a person with hyperthyroidism or
Mm.
Graves' disease?
Yeah, maybe I'll start with the Graves' disease because that's a little bit trickier. Graves'
Mhm.
disease can be a rather devastating disease when it's severe. And I have seen some very severe disease states with Graves' disease. The one I like to think about is, or I don't like to think about it because it was just so awful to see, was a woman who came in to see me. And I walked into the room and I could actually see her thyroid pulsing.
Oh,
She had
yeah.
such severe hyperthyroidism going on. And she had actually gone to a nutritionist. She really wanted holistic care. Her primary care physician really rejected that, referred her to endocrinology, and she bounced around to 2 to 3 endocrinologists and couldn't get the care that she needed because everyone kept rejecting and not listening to what she wanted. And so she went to see a nutritionist who actually put her on more thyroid, which was a really big problem. But so anyway, it's a really more complicated disease to treat. When the disease is severe, we really have to bring that autoimmune process under control. I'm treating those patients with methimazole. I might be putting them on beta blockers to control their autonomic symptoms and help them sleep. Getting the right ophthalmologic care, especially if they have the traditional exophthalmos. So really, traditional medicine is at the heart of that, but also managing the swinging back and forth. A lot of my patients do who have Graves. They're swinging between Graves and hypothyroidism, and they're exquisitely sensitive to those two conditions. And so as a practitioner, I'm a person who is sometimes managing methimazole and Armour thyroid at the same time, for example,
Mm.
where that is not something that traditional endocrinology does. So it's a little bit more aggressive. And again, it depends on the person, but we really want to get that under control. There can be severe consequences to not treating Graves. Hypothyroidism it can be quite devastating as well, but it's something that I think that there's more choices up front that you can use. So when somebody's being diagnosed with hypothyroidism, it sort of depends on whether they're coming in as autoimmune with positive TPO antibodies or thyroglobulin antibodies or both sometimes, or if they have subclinical, no antibodies, and how severe their disease is at the onset. Is their TSH 50 or is it 5? But I'm having a conversation with them about their options for treatment. I'm asking them about their own research, because people go and look and want to have a certain way of being treated, and I honor that. I think that's really critically important. So we use things like levothyroxine and Synthroid and Cytomel T3, liothyronine. Sometimes patients are already on those on Synthroid, and we add some Cytomel and they feel better, or liothyronine. We get into the combination T3, T4 combination medications like Armour, NP Thyroid, Westhroid, et cetera. Those are a great option for people, especially if they've never seen T3 in their system before. That's usually where I like to start if I can. And I love that option for people because it gives them that just additional T3 that helps them to feel better faster. Sometimes we compound. We take T3 and T4 and customize the medication. We put it in a sustained release capsule or an immediate release capsule, or sometimes we're using both. And then we're really wrapping lifestyle around that. We're looking heavily at nutrients. We're looking at how do we get the appropriate selenium, magnesium, iron, iodine in the system, measuring those things, seeing who's deficient, and then treating those patients with either supplements if they need them or focusing on nutrients in their diet so that they can support their thyroid optimally. If they have autoimmune disease, then we also get into things like a gluten-free diet, which has been really helpful in patients. I just had one yesterday who completely normalized her antibodies with a gluten-free diet, completely normalized it. And LDN, low-dose naltrexone, which is really an amazing accomplice in the autoimmune process. And again, I've seen some really incredible turnarounds of autoimmune disease with low-dose naltrexone. Yeah. So that was a lot, but
it's okay. I'm currently on low-dose naltrexone too, and I'm finding that it's helping a lot for my symptoms, especially with mast cell histamine issues too that I'm having.
Totally. So, yes. Absolutely.
So with the natural desiccated thyroid situation, there's been some recalls lately. Do you find that most people are going to the T3, T4 combination method with compounding? And is that your typical route?
You know, it's really tough. It sort of depends. A lot of it's driven by cost for a lot of patients, because the tricky insurance companies were covering their NP thyroid, which was, recalled. And I honestly have been at this for so long. I've seen all of them recalled at one time or the other. I mean, they've all gone through like, oh, we can't get Armour, now we can't get Westhroid, and so it's not, we're not pointing the finger at one or the other. Some people will switch to another a desiccated product and do just fine. Sometimes their insurance companies punish them for it, which is a bummer because they're on NP thyroid, it's very inexpensive, and then they can't get it anymore. They go to Armour and it's $60, $80, $100 a month, and then compounding it is actually less expensive. So again, it just sort of depends on the person's circumstances and what they can afford, what they want to do with their care. If they want to switch to synthetics for, at least temporarily, I just honor those conversations and collaborate with patients on what makes sense.
Great. And so you touched on this a little bit too. What other things do you typically screen for aside from the nutrient deficiencies and other sex hormone or other hormone issues there with a thyroid condition?
I mean, there's probably not an area that I wouldn't potentially delve into in the right patient. But I think the biggest one, and we didn't go into this in a great deal, but adrenal function has so much crossover to thyroid. And it can be a prime reason why people make too much reverse T3 instead of their traditional, free T3. So looking at looking at adrenal function can be so helpful. The symptoms also have a lot of crossovers, confounded with, gosh, we're just not getting you where we need you to go. Let's look at adrenal function. Let's look at estrogen, progesterone in that perimenopausal woman, or that woman who has maybe some other hormone dysfunction that's presenting. But in addition to that, I think looking at gut health can be incredibly important. Looking at food intolerances, looking at histamine and mast cell activations disease can be really helpful in uncovering some of the reasons why people get into this situation and why they can't seem to move forward despite an adequate thyroid regimen. So gut health is big. I also look at neurotransmitters in patients who have a lot of prominent mood symptoms with their thyroid or the foggy thinking. You can do urine histamine and histidine as well during that with that methodology. And in some cases, I actually look at genetics. I'm looking at DIO1, DIO2, which in certain people can be associated with poor conversion of T4 to T3 in the brain. And so despite adequate levels, we test their blood, everything looks great. They just are like, my brain does not feel like my thyroid medication is working. And so for those folks, understanding their underlying genetics can be really life altering and can really steer us towards maybe a little bit more T3 than we would otherwise allow, or treating those enzymes, those DIO1, DIO2 enzymes specifically, can be super helpful for some people.
Right, too. And infections maybe as well, depending on what they're presenting and their symptoms.
Absolutely. Lyme can, and co-infections can get in the way. Other autoimmune conditions besides Hashimoto's and Graves' disease. So many things. I mean, this is where having a functional medicine doctor who is willing to peel the onion with you. I think it's a criminal to not keep going when somebody does it. Sometimes people just feel great. You put them on thyroid medication and they're off to the races. Others, it takes some time and you have to be able to hang in there together.
Yeah. And that's where I think the traditional model is failing for a lot of people, because it's 10, 15 minutes for an appointment and you just can't get that in a 10 or 15-minute appointment.
You simply can't.
Why do you think aside from the time in the office, why do you think general practitioners are having such a difficult time diagnosing and treating thyroid patients? There are so many people out there that are just falling through the cracks.
So many people, and this is why you exist, Denise, because there are massive amounts of people who are going into their physician and saying, I feel like I might have a thyroid problem. I mean, they're serving it up on a platter. And unfortunately, I think because of the transactional nature of traditional practice, and I'm not going to throw my traditional colleagues under the bus. This is not their fault. They want to help people. They are in a position of being in a payer system and a traditional healthcare system that does not honor the physician-patient relationship, but rather treats it as a commodity. And so I like to call it sort of big box healthcare. We're in, we're out, we're going through the drive-through, and that's how it feels as a patient. Doctors also simply don't really understand thyroid very well. I remember learning about the thyroid when I was getting my endocrinology training. I got my endocrinology rotation as a medical student at Cook County Hospital in Chicago, which was an amazing place to train because I saw it all. But I remember learning about thyroid, and I remember thinking, boy, there's all this stuff going on with thyroid, and yet all we do is check a TSH. It never really made sense to me why you would only do a TSH. And so when I got into functional medicine and I realized that there was this huge repertoire of things that you could work with and fully understand, I think that's when it really kind of solidified in my own knowledge that that's how we should be approaching thyroid. So I just think the training isn't there. And there is zero nutrition training. So you ask a traditional physician, what nutrients support the thyroid? Yeah, they'll tell you iodine. That one makes sense. But everything else, it's just not there. It's just the knowledge base just isn't there. So it's too bad.
And iodine is also a tricky one to prescribe, not prescribe, but to recommend to a patient and monitor.
Absolutely. So, yes, you have to know what you're doing. You can hurt somebody.
Absolutely. Exactly. All right. So regarding your practice with Vytal Health and telemedicine there, for the patients and audience members listening today, what would you like them to know about telemedicine options for their care? How would it be different? How could it work for them?
Yeah. Oh, yes. I'm a little biased though. I think the key is that there are so few of us practicing integrative and functional medicine relative to the larger men, that if you don't have a physician who practices this way in your community, who are you going to go see? It's a tough situation for a lot of people, or maybe they just simply don't like the choices that are offered in their community. Having the ability to access a practitioner via virtual care works really well for thyroid because most of this is conversational. The great majority of what we're doing when we're consulting with the patient about thyroid is talking. And people are used to talking on video now. People are used to talking to their friends and family on FaceTime. And, this is just the way of the world. And so it's a very good conduit for being able to deliver this type of care. You don't need to be seen in person. If we suspect that you may have an enlarged thyroid or a nodule or something, we can always get imaging. We can always do ultrasound, or we can send you to your doctor and have your thyroid be examined. But for the most part, 99% of what we do with thyroid is really getting the history, understanding your value system, understanding what's happened with you, what's worked, what hasn't worked. And all of that is something that can easily be done via telemedicine. So I think it's a great model for thyroid care. Obviously, we offer lots of different physicians. All of us have expertise in thyroid and managing thyroid naturopathically, traditionally, functionally, from an integrative medicine perspective. So really you can find a doctor on our telemedicine platform that matches your value system and the kind of care that you want to receive. So it's a great form.
And they'll be paired with someone that's licensed in their state, though.
Exactly.
Correct? Right. That's
yes.
how it.
Yes. So it's interesting. COVID has really created such an interesting dynamic with telemedicine because at the federal level, a lot of these artificial constructs that were existing in telemedicine prior to COVID, for example, in some states, you had to be seen in person first before you could have a telemedicine visit with a doctor, which makes absolutely no sense. That's the whole idea behind telemedicine is that, gosh, why would you need to be seen in person first? So all of those kind of things fell away. You could see people across state lines. You could prescribe across state lines. So there was a lot of stuff that really relaxed those laws. And then at the state level, it's a little bit different. And physicians are licensed at the state level. So it can be a little bit of a quagmire. And it's really difficult, I think, for patients to understand all of that. And that's why platforms like us exist to help you navigate what are my choices in my particular area and how do I pick the right person for me based on licensure, based on my needs, based on my value system, what do I want in my care. That's why I think we can be a great resource for people.
Yeah, I think that's great. Right now I'm seeing a practitioner in Salt Lake City, and I'm in Utah, so it's been fantastic. And I know prior to COVID, they had the rule, well, you have to have at least one in-person visit per year, and now they don't seem to know what's going to happen next with COVID.
Well, last I checked, yes, right. The last time I checked on the American Telehealth Association's website, I think there's something like 500 or 600 legislative bills in front of Congress related to the practice of telemedicine. So it is a very dynamic space. And I think that ultimately what we would like to see is if you are in a telemedicine business or practice and your physician is licensed anywhere, that there's no reason why a physician who's licensed in the United States of America, in one of the states, couldn't see a patient in another state. So I think a lot of these things are going to change over time, thanks to COVID. I mean, really, that was the instigator for a lot of this, that we're going to really see some nice changes around this. But it is very dynamic and hard to navigate sometimes. So we like to try to be a resource for people.
Great. All right. Well, I think we're going to take some questions. If you have some time for maybe 10 minutes or so for some questions from our audience. And I understand too that Vytal Health is offering $50 off the first consultation.
Yes.
Let me put that in the screen here. So
perfect. We have a code that you can use.
Can you hear me? Okay, so I put it in the screen here. Vytal Health has a coupon code, $50 off first consultation with the code ThyroidChange 50. So I'll be putting that in the link too, or I'm sorry, in the comments so people can see it as well. So let's bring you back into the stream here, and let's take some questions from the audience.
Great.
So there was an event page that I created for this, and I know there were a couple of questions there first. So let me go to that. One moment.
Okay.
I had it here a second ago. Just give me one moment. Okay. So in our discussion there is a person Okay. Okay, Madeline Plua, how does she diagnose adrenal fatigue? When to use adaptogens versus adrenal glandular versus low doses of hydrocortisone? Good question.
Ooh, that's a great question. That's super packed, though. That's like a whole other topic. Okay, let me see if I can boil it down. So, testing. Salivary testing is typically what I do. It's a 4-point cortisol at 4 different times during the day. So, we capture that diurnal cortisol rhythm, the peak of cortisol in the morning, and then going down throughout the rest of the day. So, we want to see where the cortisol is in different points throughout the day. And typically, we do a salivary DHEA, one of the precursors to cortisol, to help define where, if anywhere, somebody is on the adrenal fatigue spectrum from stage 1 to stage 3. And then depending on whether cortisol is high or cortisol is low or a mixture of that or just flatlined across the bottom is kind of how we decide which adaptogens, when in the day. Do we use glandulars, or do we actually go to hydrocortisone for a period of time to restore thyroid, just to restore adrenal function? It really depends on where you are in that adrenal fatigue spectrum. So typically adaptogens are used when people are high and low, but still in the curve. Glandulars are used when people are very low, and hydrocortisone is used when people have had very prolonged low levels of cortisol throughout the day. So that in a nutshell, it's obviously much more nuanced than that, but in a nutshell, that's kind of how we would approach it.
And do you combine them sometimes? Combine the therapies with hydrocortisone, glandulars, and the adaptogens?
We do, depending on where people are, or we're weaning on and off. So we may have people who are on adaptogens and hydrocortisone, or adaptogens and glandulars, for example. And then we're doing a lot of support nutrients, the Bs, the Cs, vitamin D, making sure that people have enough adrenal support with nutrition, managing their stress, appropriately helping them exercise, because that's a key piece. I get a lot of adrenal fatigue folks that come out of, these are my marathoners, my triathletes, my folks who teach a strenuous exercise class every single day. So helping people go transition into their exercise practices and support their nutrition throughout the process is incredibly important as well.
Okay. All right, thanks. We have another one from Linda Stites. She has a question about raising her dose of thyroid medication and the symptoms she's feeling. So let me read this. My thyroid levels never seem to be stable. No matter what I do, my TH level is always too high. When I switched to natural desiccated thyroid medication, my symptoms did improve significantly, but I'm not where I should be. As I increase my dose of medication, should I do so till I feel my symptoms are better under control? Or should I increase until my test results fall into acceptable range?
Ooh, that's where I want to say, take that or and throw it out the window, because I would say both, right? I mean, I would say this is one of those kind of situations where knowing a little bit more about that individual's, maybe their gut health, their genomics, perhaps this is an absorptive issue. Perhaps this is a conversion issue. Maybe there's adrenal function issues in the way, or other hormone functions in the way, or toxins, too much fluoride or too much, there's incredible amounts of toxins that people carry, or toxin burdens that people carry around. So maybe there's other things that are contributing. But I think you have to hand in hand the way that somebody is feeling and their numbers. And sometimes you have to marry those in very, very non-traditional ways. I will tolerate, for example, somebody's T3, free T3 being a little bit high normal or a little bit over the edge of normal if they feel fine. Because that, again, might be one of those DIO1 or DIO2 people that really just need a little bit more T3 than the average person. Conversely, if they're having terrible palpitations and diarrhea, we're dialing back. But I think you really have to look at the individual response and the numbers, and have a doctor who recognizes how to treat that in a very specific way.
And it says, I noticed here at the end, she writes, increasing her dose always has had unpleasant side effects. So even though her numbers aren't where it should be, increasing, she still doesn't feel good. She doesn't feel good. So why is that,
So why? Is it too much reverse T3? Is it the adrenals? Is it gut? Is it like what's under that? That's something that just needs to continue to be unpacked. You can't take the thyroid and put it in a box. It's too all encompassing.
This case deserves an integrated functional medicine approach
Totally.
to dive
Totally.
deeper, for sure.
Yep. Agreed.
Okay. Diane Davy, having always been a night owl, I have successfully settled to night shifts for the last 10 years. And so she says now that she had thyroid nodules removed from her thyroid at age 12. She's on levothyroxine to suppress her overactive thyroid from working. So she has night shifts, and she's been sailing through her night shifts now with no problem, and this different schedule from the rest of the world, and her dosing of the thyroid medication. She's age 44, but now her work is trying to force her into switching shifts to the day shift now. And she says, "Am I right in my plea against this? As I'm concerned it will upset my body's natural preference of being a night owl and send my thyroid haywire in response." So
Yes, you are right to do that, Diane. If you tried to make me work at night, we would have a problem on our hands, because I am not a night person. In the time that I've had to spend in my training in the emergency room and delivering babies, I'm the worst person for that job. So I do think we have to honor people's natural inclinations for what works best and what feels best for them. So I would be saying, work with a physician who can support you. There's no medical reason why somebody shouldn't allow, this is an Americans with disability issue. We have different people who have different needs, and they need to be able to have employable work, have an income, and to force them to do something that their body just naturally does not adapt to doesn't make any sense to me. So I think that sounds like something that needs to be dealt with at the level of getting a doctor to support you in your plea to stay with what your body's natural rhythms. And I would throw in, take melatonin if you're a night owl. Just because there's so many studies looking at melatonin deficiencies in people who are up at night. And it's linked to other problems. So, just making sure that melatonin is part of your repertoire would be important.
She also said she was taking vitamin D too, since she's sleeping most of the day because of her shifts.
Totally. Great idea.
Okay, next person here, Shyam Makanti Ray. I was reading through this earlier, sort of a long question, but I was able to condense it into something a little more concise. Sounds like they want to know, what is the likelihood of thyroid disease being passed down to your grandchildren or your children if both you and your daughter, there's a strong family history of hypothyroidism?
Yes.
And is there any way to avoid it? Any measures that can help to prevent it in those children?
Yeah, that's a great question. There are definitely, we think that probably in Hashimoto's disease, and I'm going to throw Graves in there, but particularly Hashimoto's disease is something like 70 to 75% hereditary. So it's incredibly hereditary. Wow. And when you talk to people, and they have Hashimoto's, there's always family members, whether they know that they have Hashimoto's or not. Oh, the hypothyroid here, right? It's just, so we know of at least 7 or 8 genes that are pegged for hypothyroidism, and also several that cross over, but as many on the hyperthyroidism side of things. You can't obviously change your genes yet. Hopefully someday in our lifetime we will be able to do those things. I can't wait, because I have autoimmunity as well. But I think what we can do is know that there are certain things that flip the switch, and one of them is probably nutrition. We know that gluten-free diets can really make a huge difference for people. And when I have seen people in clusters of autoimmune families who have had a repertoire of family members who have hypothyroidism, but that there's also celiac disease in there, and there's type 1 diabetes, and I just get nervous, because we don't know what the mechanism is, or at least I don't. But there is so much conversion between these problems. And so gluten, the GMO gluten that we get here in the States is definitely something. If you have a strong family history of autoimmune thyroid, I would be saying all of you should adopt a gluten-free diet until we know more. And then I think, just again, self-care goes a long way. A lot of times when we're looking at genes, it's the milieu in which that gene is expressed, and whether or not we have a lot of circulating cortisol, whether we become obese or not, whether we are physically active, the epigenetics, can make a huge impact on whether that gene is expressed. And there are probably infections that are harder for us to control that come along and also are part of the systematic switch of the on to the gene. But if you're good at self-care and you're healthy, it decreases the likelihood of contracting those potential triggers. So this is a call to action for being a person who's health conscious and then more specifically gluten-free.
Yep. Okay, we'll have time for maybe one or two more if you're okay.
Yeah.
Angie Berman. So do you recommend pill supplements versus actual food nutrients?
For thyroid support, I'm presuming.
Yeah.
I think it just it just depends on the person. So, and it depends on your levels. And so we like to measure things. I don't like to guess if I can help it. I really want to kind of know where people are. So if you're a person who can eat enough of the foods that contain the nutrients, then great, more power to you. If we can get it from food, food is the best way to get any support nutrients across the board. But for example, I am nearly vegetarian and I have problems with one of my genetics that's a problem with B12. And so I have to take very high doses of B12 supplement. I just can't get away with it in my diet. So I think it, again, just depends on the person, depends on what their food ethics are, depends on their dietary habits, all of the things that are necessary to support that patient and make sure that they're getting the needs. But I go to food if I can. I don't want people to be swallowing handfuls of supplements if they can get away with it.
Mm-hmm. Okay, so for a person who is interested or their doctor is thinking they might need T3, T4 combination, or they need to switch medications to maybe natural desiccated thyroid, Tarnia Moore says, is it dangerous to just stop taking levothyroxine with low thyroid, or if they feel like it's not working for them?
She says, no, I mean, no, it's not. I mean, it just sort of depends on which dose you're on. I get a question a lot of times is, can I stop levothyroxine and start Aurora the next day? And I'm like, absolutely, you can. You don't have to wean off of it. Or if you're on a small dose, you're on 25 micrograms or 50 micrograms of levothyroxine, you're like, I'm not sure this is doing anything for me. Dropping a dose like that is not going to make a huge difference. So no, it is not unsafe. But you know, if you're transitioning, you stop the medication, the levothyroxine or Synthroid one day, and you pick up your T3, T4 combination the next day, and all is well.
Mm-hmm.
It's not terribly complicated.
Yeah. Do you feel that there's a long adjustment period between like moving from one to another?
No, these are very fast acting medications, right? I mean, they don't have a long half-life in the body. So levothyroxine probably peaks in 3-4 hours and is out of the system at 8 or 9, maybe, depending on how it's absorbed. Same with the Aurora. So the only difference would be is if you're not on T3 before, for example, you're on levothyroxine and you're switching to Aurora or something like that, you can really notice it. And I get people in several days, you know, sending me messages and saying, gosh, I feel so much better already. Should I feel better already? And if your body has not seen that T3 and you really need it, yeah, it can make a huge difference really quickly. And people notice that change very, very fast. So yeah, that's the only difference, but it's usually a positive thing.
Great. All right. Really quick, I have just a burning question that I have. What about what about international patients? Can they currently see you guys for no, not yet?
Not could you tell my face?
Yeah.
No, not yet. So this is where I mean, obviously by video we can go. Well, hopefully they'll get us to the moon at some point if people end up living there. But it's so from a method standpoint, yes, but from a license and liability perspective, we just don't have those international capabilities yet. You know, eventually we will. And again, it just sort of depends on the telemedicine movement and how that works. But it gets complicated when you have stateside physicians trying to treat patients in other countries. There's obviously time differences to deal with. That's the least of our problems. But no, we're not in a position yet to see patients internationally, unfortunately.
We'll keep our fingers crossed for that.
Yeah, I was going to say.
Future.
Right, absolutely. Hopefully we'll get there at some point.
Well, thank you so much, Dr. Mullen, for joining us today and for answering our audience's questions. We really appreciate your time and all of your knowledge regarding thyroid disease and an integrative approach to thyroid disease and how to treat it and diagnose it, for example. So
glad to be here, and I hope it's helpful. I hope it encourages people to get the kind of care that they deserve.
Absolutely. Well, thank you again, Dr. Mullen. It was great seeing you.
You too, Denise.
Take care.
Thanks so much. Have a good one.